Hello everyone, my name is Martin Hoenigl. I'm Associate Professor for Translational Mycology at the Medical University of Graz in Austria, and it's my great pleasure to welcome you in my function as the President of the ECMM to the fourth ECMM Healthbook live webinar with the hot topic Antifungal Resistance in Yeasts, Current Status and Future Perspective. So this is of course a webinar, but nevertheless we have also virtual host countries, which is today Switzerland and Austria. And we've went through the number of participants and registrants, and I want to of course welcome everyone here, including participants from Switzerland and Austria, but we also have a big number of researchers and scientists and physicians from India, which I want to welcome specifically, and also from the Ukraine, which makes me particularly happy that you are able to join our webinar. So today we will hear from three speakers. First of all, Matthias Ecker will start off with a clinical case outlining the problem of Candida drug resistance in clinical practice. Then we will head over to a translational talk from Professor Cornelia Lass-Flörl from Innsbruck on antifungal resistance mechanisms and more in Candida species, and concluding really our webinar with a clinical session on Candidemia, Candidiasis, and deep-seated Candida infections after surgery by Dionysios Neofytos. So this webinar is provided to you by ECMM and Healthbook in a collaboration and is supported by Gilead Sciences and further co-sponsors. And with that, it's my pleasure to hand over to Juergen Prattes. But before I hand over, I need to make some housekeeping remark. You're always able to ask questions during the talks via the online tool, and we will answer each of the questions during the discussions after each of the talks. And if there are too many questions, the speakers will go back to the online tool and answer the questions during the webinar via the online tool. And with with that, I want to hand over to Prof. Dr. Juergen Prattes, who is also from the Medical University of Graz, but currently also for a research here at the University of Cologne in Germany. And it's my great pleasure that Juergen will guide you through this program tonight.
Thank you very much, Martin. Also very warm welcome from my side, from Germany currently. As you heard from Martin, we have quite an interesting topic today. And we will cover everything basically from clinical cases to translational sessions to really give a good overview on the broadly emerging problem of resistances in fungal infections, and today especially in yeast infections. And to start today's webinar, we will have first a talk by Dr. Matthias Ecker. He's an infectious diseases physician and researcher from the Medical University in Graz, Austria. And his research is focused on fungal infections, no surprise, primarily diagnostics, biomarkers, and also treatment and new antifungals, which is kind of an interesting topic nowadays. So Matthias Ecker will give us an overview about a clinical case or clinical cases, where he will try to show us how resistances in yeast can make our life as physicians, microbiologists or pharmacologists, make it more difficult basically to treat our patients. So Matthias, please go ahead and give us your presentation.
Yeah, Juergen, thank you so much for the kind introductory words. I just wanted to say that I'm a research fellow, and being an ID physician would be my my big dream. But yeah, I'm just starting off with my clinical experiences. So some of the clinical questions, my experience until now is a little limited. But without further ado, I want to start with my presentation, which is called Drug-Resistant Candida in Clinical Practice, Presentation and Complications. So I'll start with case one, which is about the middle-aged man who was transferred to a hospital with abdominal pain and fever. In his past medical history, he has type 1 diabetes, peripheral artery disease, and the status of the below knee amputation. And I want to point out his surgical history first and foremost, where you can see that he has had has a colostoma. He had a thigh abscess which was incised and drained, and he also has had a retroperitoneal abscess 1 month ago, which was drained CT guided, and this already grew Candida albicans and Candida glabrata. Concerning his medication, he has his medications for his diabetes and currently an ongoing therapy with the echinocandin micafuncin. His physical exam showed an increase in the systolic blood pressure, and in his abdominal exam, we found that this was diffusely tender and most prominent on the left upper quadrant. His extremities were, we found the bilateral BKA stumps, of course, which were well hidden, no signs of infection, and otherwise his physical exam was unremarkable. His initial labs showed elevated platelets and elevated CRP and a low albumin. So we decided to do a CT scan in this patient and found an heterogeneous mass, which showed invasion to the adjacent liver and also nodularity and thickening of the gastric body, including periportal and omental deposits, which were also concerned for an invasion of the left anterior abdominal wall. So overall, these findings were concerning for possible malignancy, but also at this time point, the radiologist wrote that a diagnosis of exclusion would be atypical infections such as invasive fungal infections. So concerning the findings at the gastric curvature, we also did an endoscopy in this patient and found that the right anterior wall and subendothelial 5 centimeter bulge, which was also investigated via ultrasound. And these findings included heterogeneous hypoechoic to hyperechoic lesions in the same location as the bulge was macroscopically found. So a fine needle aspiration and biopsy was performed, and I want to give you an overview about the micrological findings and his antimicrobial therapy so far. So we have the history of his retroperitoneal abscess, which grew albicans and Candida albicans and glabrata, for which he received fluconazole for 3 days and was then switched to micafuncin, which is now his therapy for 30 days and ongoing. In his fine needle aspiration, we found that this was negative for acid-fast bacilli, but in the GMS stain, we found multiple fungal organisms with pseudohyphae, which were suggestive of Candida species. So the culture ultimately grew Candida glabrata, and also his fungal studies at this time showed positive serum 1,3-beta-D-glucane. However, his serum Aspergillus galactomannan was negative at this time. So now I want to talk about this anti-fungigram of the Candida glabrata, where you can see that Anitula fungin was in the susceptible category, whereas fluconazole showed resistance, and micafuncin was reported in the intermediate category. Due to this intermediate category and his history of this retroperitoneal abscess, where we already found Candida glabrata, and the absence of clinical improvement, at this time point, we added liposomal amphotericin B in addition to micafuncin as a combination therapy. So I want to give you a quick overview about the emerging Candida species, where we can see on a global scale that non-albican species are increasing worldwide. This does depend a little bit on the geographic location, where we can see that Candida glabrata is primarily dominant in North America, in Europe, and in Australia, whereas Candida parapsilosis is the is dominant in South America and Japan. And this, of course, Candida albicans is the most abundant species, but this is about the second most abundant non-albicans species. So to date, probably more than 40% of invasive candidiasis is caused by non-albicans Candida species. There's an increased concern for fluconazole resistance, and it is also considered that due to a significant number of invasive candidiasis cases are treated empirically, because we know the gold standard for diagnosis is still the blood culture, which is accompanied by a low sensitivity between 20 to 70%. We think this dynamics might be still underrepresented. So I want to quickly show you a first-time publication of the WHO of a fungal priority pathogen list, and we see here the critical priority group and the high priority group, and we can see Candida glabrata here in the high priority group. So why did the WHO publish this data? It's because an overall rise of invasive fungal infections worldwide due to, for example, increased accessibility to immunocompromising therapies such as immunotherapy and chemotherapy. We also know that the climate change does lead to an expanding incidence in invasive fungal infections, and also we appreciate no new risk groups for fungal infections, like patients with chronic lung diseases like chronic obstructive pulmonary disease, or patients with liver and kidney diseases, and of course patients with viral associated, first and foremost, pulmonary invasive mold infections, for example, influenza or COVID-19 associated pulmonary mold infections. So if you're wondering how these how the development of such a priority group is approached, the WHO used multi-criteria decision analysis and placed emphasis on 10 different categories. And I just wanted to point out that these categories were also weighted concerning their importance, and resistance was with 38.5% the most important category concerning the weighting. Short overview of treatment. So we know that echinocandin is the preferred initial therapy, and I just wanted to point out here that the alternative initial therapy does depend on the Candida species which is obtained, and as we see here in Candida glabrata, the alternative would be amphotericin B here, which was also added in our case. So back to our patient, regarding his CT course, we can see an overall improvement of the radiological findings. And after 10 days and clinical and radiological improvement, there was again on some source control and an aspiration of the gastric mesh, and the left abdominal drainage was placed. And these again grew Candida glabrata, and here you can see the contrast between the two anti-fungi grams, where you can see amphotericin B still with the same MIC, and Anidula fungin, which was susceptible beforehand, is now in the intermediate category, and Mica fungin, which was before in the intermediate category, is now in the resistant category. So we can see that these the fungal cell developed resistance due to increased environmental stress due to the therapy. So now to the overview again, we have these findings of the gastric mass and the abdominal drainage, which saw Candida glabrata again. So we just decided to step down to Anidula fungin, which was in the intermediate category, and this was his treatment until this time of the case. So due to the improvement of the patient, we needed an oral option. And when we quickly go back, we see that the azoles are not an option, and echinocandins are only available as intravenous therapy. So we needed a different drug and did an explant use authorization for manocepics. Just a quick overview about drugs in development in the treatment for Candida infections. I can, if we take a look at these two figures, we see fosmanocepics here in the middle, which shows a new mechanism of action by inhibiting this GWT1 enzyme. So this is a promising drug for, again, for future therapies of invasive candidiasis, and also as an oral available drug. In this case, probably also ibrexafungerp would have been an option, and rizafungerp with this, which is a new echinocandin with very long half-life time, would have been a potential option. Here you can see fosmanocepics with good activity against various Candida species, and one exception would be Candida krusei here. So concerning the hospital course, in his last CT, abdomen pelvis, we saw a stable disease. Basically, his left low abdominal drain was removed and he was discharged to nursery home. So I pointed out that the non-albicans species are emerging, and also the resistance in this species. And this brings me to the second case, which is about a 25-year-old male with a polyendocrine autoimmune syndrome, which is called APECED syndrome, which stands for autoimmune polyendocrine candidiasis ectodermal dysplasia syndrome. So this is a genetic disease which primarily affects endocrinological organs, including the liver or the adrenal glands. So this patient had also flaws of autoimmune hepatitis and an autoimmune morbus Addison. And also part of this syndrome is our chronic Candida infections, which might be recurring and recurring all the time. And this is why this patient was at care at our clinic for over 7 years. He had recurrent Candida infections, and this patient was primarily affected in the oral cavity and the esophagus. So concerning his history, he was most of the time tried to be treated with local therapy, including miconazole nitrate, chlorhexidine, and amphomonoral. Concerning the azoles, voriconazole was at some point at the borderline intermediate or resistance category. Yet he had this recurrent autoimmune hepatitis flaws with increased liver parameters. So azoles were most of the time not an option here. We also tried outpatient intravenous therapy with an echinocandin, and also intravenous therapy with amphotericin B. We also tried the addition of an selective serotonin reuptake inhibitor, where we have the reference of Professor Lass-Flörl, who showed the antifungal activity of SSRIs against Candida species, and observed this in women with vulvovaginal candidiasis. These medications sometimes led to absence of recurrent infections. However, our patients showed weak response to all local and systemic antifungal therapies, and although we really tried like all possible options. And here you can see on the right his antifungogram, where we can see that this Candida albicans is resistant to fluconazole. So regarding his clinical course, as I mentioned before, he had recurrent infections and swabs of various reasons. He also had sometimes fluconazole susceptible Candida albicans, for which fluconazole was then his long-term therapy and prophylaxis therapy. And just recently, he was again at our outpatient clinic, again with marked clinical findings of oral candidiasis and as well as esophageal candidiasis. His primary complaints were dysphagia. He had difficulties with swallowing solid food, and from a cultural oral swab, we again see that we found an fluconazole resistant Candida albicans species. So we wanted to find an appropriate oral therapy for this patient and included him in the Fury study, and started with the new antifungal, which I quickly mentioned before, ibrexafungerp, as an oral therapy. If we take a look at this overview of activity, again, we see ibrexafungerp has good activity against several Candida albicans species. So we started with the study medication. We're at 3 tablets at once, dosed every 12 hours. And after 1 month of treatment, we saw a complete clinical response of his findings. This was a picture like somewhere in between at a study visit, where we can see that his chylitis already improved. Unfortunately, I don't have pictures from after the treatment course. So this brings me to my conclusions. So antifungal resistance is rising. First and foremost in the non-albicans species, but also in albicans, Candida albicans, when it causes chronic infections. We know that resistance mechanisms are triggered by any environmental stress, which is applied to the fungal cell. And this is somehow in contrast to liposomal amphotericin B, where we can see, when you think about the antifungogram, the MICs stayed the same. And we do have a lot of new antifungals which may provide alternative options for monotherapy or combination therapies. And we also do see synergism between, for example, ibrexafungerp and amphotericin B, and fosmanogepix and amphotericin B. And again, the WHO just recently published for the first time this fungal pathogen priority list, underscoring the global importance of invasive fungal infections and the complications which come along with the increase in resistance. So with this, I want to thank you very much for listening. And I hope this was some kind of introduction to the problems we're facing. And I'm happy to listen to the speakers, which now talk about these resistance mechanisms in more detail.
Thank you very much, Matthias, for this nice overview. I think it nicely highlighted what kind of challenges we are facing in our clinical routine. We have a couple of minutes for questions. And Martin, if you're happy to do so I will walk through them. Maybe start with a question from the audience in respect to echinocandin therapy. So the question is, what are the most common side effects we are seeing when we treat patients with an echinocandin? Do you have any comments on that?
That's a good question. I think overall echinocandins are do show very beneficial profiles of side effects. So most of the patients do well on echinocandins. What I would primarily be thinking about in some case, or Martin, could you?
Maybe I can also jump in here, Matthias. I think echinocandins are the infectious disease's most favorite antifungal. Yeah, so we do not have any that much difficulties with drug-drug interactions with side effects. So side effects are kind of rare when you use echinocandins. Sometimes you can see kind of anaphylactic reactions similar to any other antimicrobial use, basically, so rash or something like this, but it's actually rare. Sometimes also very rare, you see some kind of elevated liver function tests, but in general, they are very good tolerated. And that seems also to be true for other glucane synthase inhibitors, which is what Matthias just mentioned, the ibrexafungerp, other class with antifungal, but similar mode of action, not the same, but similar mode of action, We also see very good tolerance there and less side effects.
Good point. The only thing to add for ibrexafungerp, because it's an oral agent, we have these cases of nausea that really drive discontinuation. But this seems to be less a problem with the IV short course echinocandin treatment. So it may be something we're just seeing because we're now using it very longer term, also with ibrexafungerp as an oral agent.
That's true, yeah.
Because Juergen is the PI actually of the ibrexa study in Graz. So did you see this in one of your patients, Juergen, as well?
The nausea and the vomiting?
Yeah.
Yeah, in basically 2/3 of the patients, yeah. So because you start there with a loading dose, and it seems that this loading dose is somewhat difficult to basically to tolerate. But some also have like prolonged symptoms on ibrexafungerp, but you can actually reduce the dose there. But yeah, that's what we see. But it's not so uncommon when you use oral antimicrobials in general, I guess. Yeah, so you are disturbing the gut microbiome and so on. Maybe we can jump over to the next question, which is, I think, Matthias, maybe you just touched it a little bit. Maybe you can come back to that a little bit more in detail. The question is why micafungin became from intermediate to resistant. If there's kind of a selection pressure, if you select maybe also micafungin resistant Candida that was already there at the beginning and you can just select it out, or if it's basically a consequence of the therapy. And if so, that's my question, my additional question. Do you think that hit hard early would be good? So in these intermediate cases, should we initially start with a combination therapy, for example?
Yeah, thanks, Juergen, for the question. I think, as we saw in our case, when micafungin was reported to be in the intermediate category, we added this amphotericin B in order to go with the approach hit hard and early, and also go with the combination approach, which definitely makes sense in the early stage. I mean, the combination approach is to date limited because we only have these 4 fungal classes available. I mean, flucytosine would be a good option to add, but it's, I think, worldwide on a global scale, we're very rarely available. So, for example, here in Austria, we have to get it from Japan, I think, if we want to use it. So it's rarely available. And concerning the first question, I mean, definitely we had different sites of infections, right? But still the environmental stress, which is impacting the Candida, I think in this case is leading to an increase in resistance of this very species in the patient. So yeah, definitely, I think this selection pressure here provided through the antifungal therapy led to this change to the resistant category. Yeah.
I mean, it could even be both, right? Because we have this absence and presumably you have a lot of different Candida in the abscess, right? So it could be kind of like that some strains are selected are very resistant, but of course we know that, you know, in the presence of antifungals, especially in the presence of echinocandins and azoles, that, you know, Candida can develop resistance, right? Tolerance and then at one point also resistance. So this is something that is observed. I think we can't say antifungals because it's not with every antifungal. So it's, for example, known that this is not happening with amphotericin B, right? As you pointed out. But I think, you know, we don't have the final answer to that, whether there were some strains present from the beginning that have been selected out basically, or whether basically just the strains became more resistant. But this long-term micafungin treatment, you know, could presume that, you know, maybe the strains just got more resistance as well. But hard to give a final answer on that, I think, without any other further investigations. Yeah.
Awesome. So I think we are really good on time. There are 2 or 3 more questions in the chat. Maybe Matthias, you can have a look on it and answer via the chat. I will do the same. And with that, I'm happy to hand over to Martin, who's going to introduce our next speaker.
Thanks so much, Juergen, and thanks again for this great introduction into our webinar, Matthias. And now it's, of course, my special pleasure to introduce one of the superstars in medical mycology, Professor Cornelia Lass-Flörl, who happens also to be in Austria, although nearly as far away in Austria as is possible in our relatively small country. So from Innsbruck, from the Innsbruck Medical University. She will give a more translational overview, combining science with, also some clinical impact, and discuss about antifungal resistance mechanisms, but also more in Candida. Connie, I'm very much looking forward to your talk.
Yeah, Martin, thank you very much for this nice introduction. And indeed, Austria is a small country, but probably we have enough fungi there. So, dear all, dear outside, it's my great pleasure to give a little bit an insight on antifungal resistance mechanism, specifically in Candida. But before we jump into this topic, I think it is important to deal with some definitions. For the very first time, we have whatever we call a new definition when it comes to microbial resistance, which does mean only in vitro, which is detected by the microbiologist, and it is determined by the minimal inhibitory concentration for a given drug. But, and that's new, the interpretation follows established clinical breakpoints. So in the past, we used the term, if the MIC is higher than BK, BD, whatever. Nowadays, we move over and use the clinical breakpoints. And in addition, we can have also elevated MICs mixed in non-wild type tubes compared to the wild types. Completely different is the term clinical resistance. In the clinical setting, as already mentioned, the infection persists, and this could be due to susceptible strain, but also due to a resistant strain. There are multiple factors, and there are, of course, composite situation, which does mean that both are affected. Usually, antifungal resistance affects one drug or several compounds. Then we use the term single resistance or multiple resistance. And what we realize now, because probably it's more awareness, probably we screen much more, that multi-drug resistant is emerging. And what I would show you here is a picture from a so-called E-test. This is the test which we use, or one of the tests which we use in the lab to detect for antifungal resistance in vitro. And you see here on the plate, there was spread the fungus. Then we covered with two stripes. One is called variconazole stripe and one is amphotericin P. And on the stripes, there's a highest and a low concentration. And it is believed that from the stripes that the antibiotics differ out and then inhibit the fungus to grow. And then where the growth of, or the zone of inhibition interacts with the stripe, there is the MIC. So as an example, there is no zone of inhibition. Usually we refer this as resistant. And here we clearly see a zone of inhibition, and hence we use the term seems to be susceptible. Completely different is the term as already mentioned by our president, ECMM president, Martin. There is a difference in between antifungal tolerance, which we use in the lab also the term trailing growth or heteroresistance, which seems to be a subpopulation from a priori susceptible population, but which is able to slow in the presence above the MIC. And this is what you see here, slightly all these colonies within the zone of inhibition. Just to clarify, so my ongoing presentation will really focus on resistance or susceptible one. Next is, probably this is just let's say from an academical point of view of interest, resistance is differentiated in between acquired versus intrinsic, or with other words, secondary resistance or primary resistance. What does it mean? It does mean that acquired resistance comes over when a drug is given for a certain time, and a primary first susceptible strain may be selected, and then a resistant strain pops up. This is completely different to a primary resistance, where this resistance is independent of drug exposure. For this, I would like to give one example: is Candida cruziae and fluconazole is primary resistance, and acquired one is probably the increase of fluconazole resistance in Candida glabrata. And the primary factor driving antifungal resistance seems to be a selective pressure from an increased administration of antifungal agents. I will show later another slide. So this is just as a wake up once more. Discussing on resistance does also mean please bring once more into your focus that we have three major groups of antimycotics: the bolians, the acyls, and the echinocandins, and they differ in their target. And subsequently, in most cases, the pathomechanism behind of why a fungus is resistant is different. So major questions when I prepared this presentation, major questions which came into my mind are: how commonly does resistance occur? Is it easy to induce through therapy? How often finally does it result in failure? And how do we best present it? Maybe the whole Healthbook event for today gives some information on this, but my thoughts are that we have several limitations. We don't have really a regular survey. We have in some countries, but not in all. We use indifferent criteria. We have strong influences on human factors, let's say clinical resistance. We are dealing with different geographical areas, India versus Austria, for example. Then we use various treatment approaches. Even the diagnostic approaches are not the same. And that's probably the most important. Whatever we detect in vitro must not be valid to 100% in vivo. So these are a little bit the limitations. So now let's have a closer look to the current position of acyls. What do we know nowadays? We know that acquired acyl drug, that's the issue, and that's what's emerging, acquired, which does mean after exposition. But in Candida albicans, all over, it seems to be very low worldwide, less than 1%. So the albicans is not the problem. Whereas in Candida glabrata, the resistance rate ranged from 5 to 10%. So that's the real threat today. Followed by acyl resistance in Candida parapsilosis and tropicalis, where it is around 5%. Usually, as already mentioned, Candida cruziae is intrinsically resistant, so we never go to treat the cruziae infection with fluconazole. And elevated non-wild type fluconazole mix are most commonly observed in nowadays glabrata and Candida auris. And fluconazole resistance is emerging in Candida tropicalis and Candida parapsilosis, and exposure to acyls is the significant risk factor. This is whatever we know, although I can't really say, okay, it's after 2 weeks, it's after 4 weeks. We know it is a risk factor, and why we are a little bit failing that I can't say after 2 weeks, 4 weeks, 5 weeks is I will show you later what is the problem here. But we know that resistance has been described also in drug-naive patients. Here we discuss whether this is nosocomial or not. Other species have intrinsically elevated fluconazole mix as Inconspicua, Lipolytica, novicensis, rugosa, and so on. Cross-resistance within the azoles happens, but highly depends on species and mode of pathomechanism behind. How is the situation with the echinocandins? So echinocandin resistant rates presently are low in general, with the exception of Candida glabrata. So once more, glabrata with the azoles and also with the echinocandins. Candida albicans, and this is a little bit the opposite to the fluconazole or to the azoles, is the second most common Candida to display Candida resistance. And this is probably because it's highly prevalent in the clinical setting. What is important is that heterozygous and homozygous mutation in Candida albicans may generate different phenotypes. What is it what I would like to stress out? I would like to stress out that they could result in susceptible, intermediate, as well as resistant phenotypes. What is a little bit the difference to the fluconazole, that Candida resistance development can occur, what we've learned from the literature, after really very short courses as well as long-term treatment. But there are reports that less than 1 month, people came up and developed resistance. Same as we know it from the azoles, resistance has not been described in drug-naive patients, with the exception of nosocomial acquirements. What is unique and where is the difference in between the azoles and the echinocandins? That echinocandin use is the main driver of mutations, and that we know that isolates from breakthrough infections have elevated MICs. But also, it seems to be that the mechanism behind seems to be unique. And for Candida glabrata, which is the emergent one, it is described in the literature that after 3 or more days of echinocandin treatment, patient developed already resistant. What about the ebullience? It's completely different. Resistance is rare, and in case there are some fungi involved, in the majority, resistance is primary, which does mean that you won't trigger it. This is what we believe, because the target is ergosterol, which is not a protein, which is genetically coded. There are some strains within the species Tropicalis cruzi and lucidani showing higher MIC, but what in general is discussed, that whether the mode or the way we detect resistance probably is not the best to detect amphotericin B resistance, because most of the fungi, and interestingly, this is also valid for the molds, cluster in between 0.25 to 1 or to 2. So there is not a huge interplay in between. That's why it's a huge discussion whether we could improve. And those small numbers of strains where we saw resistance in pollen, it appears that the reason for it is a modulation of the cell membrane through depletion or replacement of ergosterol. So this is the present situation in the clinical setting and what we know, whether it's related to treatment or not. So what are the drivers of antifungal resistance? First of all, it is an interplay in between fungal genetics, which is present in the fungus, drug levels, and site of infection. So these 3 issues play together and promote resistance. And within the sides of the human body, the abdomen, which is the gut, and the oral cavity are the major reservoirs for resistance development. And that's probably simply because it's driven by subtherapeutic levels at these sites due to poor drug penetration or biofilm formation. In most Candida, acid resistance, and this is also the opposite to the echinocandins. In the acils, in the majority of Candida, we have a combination of mechanisms which prone the fungus to be resistant. In echinocandin, it seems it's exclusively only amino acid variations in the conserved hotspot regions, either FKS1 or for Candida glabrata in FKS2. So for the acils, multiple mechanisms, and that makes it difficult in the deduction. And it seems for the echinocandin, up to now, who knows what happens from tomorrow on, up to now, it's the FKS. And I think it's also very, very of great interest. Unlike with acils, drug efflux pumps, overexpression, biosynthesis, pathway modulations seems not having an effect to Candida susceptibility when it comes to the echinocandin. So from this point of view, you really realize that there are major differences in between the acils and in the echinocandins. But that's a little bit the clinical situation. Now jump into the fungus. And I would like to use the term, we never know with which microbes we are colonized. Nobody knows. But it's easily imaginable that we are colonized with fungi which have some weak points in the genome. And I'd like to mention, this could be adaptive phenotypic plasticity. What does it mean? It does mean that a fungus is able, due to stimuli coming from the environment, to change morphology, but also to change physiology, which does mean that the content of the fungus itself allows him this plasticity. And we never know, do we have a glabrata with high plasticity, or do we have one being colonized with low? So this is something we cannot influence. Same is that we don't know how strong is the spontaneous frequency of mutation in our fungi. Could be high, which is bad, could be more behaving, could be slow, which is probably much better. We could be colonized with strains who have a defect in their mismatch repair system. We call them mutator strains. If we are colonized with mutator strains, it happens frequently that resistance come over. In addition, we could have some yeasts in our body, which are easy change their chromosomal numbers, which is called chromosomal aneuploidy. We don't less about the sexual reproduction. We know that population dynamics, which is probably related to sexual production, how strong it is, how fast it is. And less we don't know what we know from bacteria, horizontal gene transfer. So these are the weak points. And if these fungi are exposed to stress, such as an antifungal, they immediately can change and adapt to survive and then lead in the clinic some problems. The molecular mechanism behind could be that the fungus comes up with mutations, with isochrome formation, which does mean more chromosomes, with aneuploidies, with a loss of mitochondria, enhanced production of stressors, which does mean those antifungals which target the stress production HSP90 fail completely, or if a fungus changes from a hetero to a homozygotic state when it comes to resistance. And this is what we call selection. We give an antifungal, we never know what's going on, and finally resistance occurs. And the resistance mechanism, which are found then, could be target site alteration, metabolic bypass, overexpression of efflux pumps, stress pathway, or even biofilm formation. So if we look once more, a little bit more in detail, some I picked out is aneuploidy. Out of a sudden, due to various stress conditions, for example, in azole-resistant isolate, out of a sudden, the fungus produces an EC chromosome. And this, in turn, can explain azole resistance. Or what we found, the loss of heterozygotes moving over to homozygotes, and out of a sudden, in a very, very short time period, the fungus is resistant. Before it happens inside the fungus, that a mutation affecting finally the whole TNA, or the whole changes in TNA sequencing. Frequently it happens, SNPs, translocation, duplication, ploidy, and deletion. And if this happens due to selection, more steps are coming up, and finally after treatment you have to deal with a resistant strain. And this is nice what we realized in 2014, quite years ago, but we had a patient where I didn't understand. In some occasion, the Candida albicans was susceptible against the echinocandins, and then it was resistant. And what we realized, that the Candida albicans is a diploid, which means there are two sets of chromosomes. And if there is affected one allele, we have a heterozygote mutation. And if this is targeted to the glucan synthase pole, 50% of the echinocandins work, let's say, and 50% are not. So heterozygotes probably could be easily treated with an echinocandin. But if the mutation moves over, affecting two alleles, then we have a homozygote situation, and the fungus is completely resistant. It's just shown here that within all the echinocandins, we realized that even such small changes have a strong influence on the MICs, and we never know which yeast is just in the blood. Is it the heterozygote, or is it the homozygote, or are both there? And hence, when we have a closer look to the echinocandin resistance, it is important to understand that which positions are affected in the amino acid sequences, or which type of mutation has a strong influence of whether there is a moderate or there is a pronounced elevation of the MICs. And this is what we know. We know it depends on the species, and well, we really know which amino acids lead. Not all, and this happens now when we go back to the literature, not all these amino acid sequence changes or mutations led to the same amount of mutations. There are differences. And even when we have here, you can go to the echinocandins, to the booleans, or to flucytosine. SNPs are a major driver in the development of resistance. So that inside the cell, I would like to conclude that point mutations gene duplications and transposons insertions seems to be the major mode of action inside the cells. And what we know from bacteria in comparison, we can't see it in the fungi up to now, so extra chromosomal elements are really rare. Same is rare is horizontal gene transfer, and up to now, there is no evidence of a pan-kingdom fungal resistosomes. These are keywords we know from the bacteria. And I would like to bring your attention to a nice overview from 2019 when it comes to the resistance. I will pick up once more, and even the production of biofilm, which itself is not related to any gene or to amino acid changes, is highly related to clinical resistance. Could be also a resistance in the lab, simply because the antifungal can't penetrate to the biofilm, hence not reaching the fungi. So as already mentioned, finally, increased efflux pumps, increased drug targets, lower content of the targets, decreased binding are the reasons why the microbes develop resistance. Once more, be aware, it's something we can't really prevent, because it is believed that we are colonized with whatever we call original fungal population. And when we have a closer look to the fungal population, we realize that we are colonized with susceptible, with a weakness in genomes, or with already resistant or inherent resistant population. This exposure to the antimycotics will eliminate whatever is susceptible, and on the other side will trigger genomic changes, which in turn then will lead to more resistance. So this is the major pathomechanism, what we believe, and I think more studies are needed whether what we can do to prevent these steps. And this is one of my last slides, where I will bring your attention beyond Candida auris, beyond. It seems that nowadays in 2020, fluconazole resistant Candida parapsilosis is moving around, and it seems that the fluconazole resistance in Candida parapsilosis led to a survival benefit of this clone, and hence spreading nowadays all over the world. First described in 2004, and now within the last 5 or 4 years, out of a sudden we realize that it's emerging like Candida auris. And what we can learn from the literature, that Candida parapsilosis is able to survive in the environment, and it is believed that specifically this substitution, which is responsible for fluconazole resistance, brought this fungus and survival overview. So I think I encourage you to go back and have a closer look, because it could be, must not be, but it could be the next threat we are dealing with. So this brings me to my first conclusion. Be aware that resistance could be induced, could be naturally. Those who are inducers is strong diaceres as well as the echinocandins. And we never know with which fungi we are colonized. If there is a fungus with some genetic weak points in a human body, it happens faster, it happens much more easier, rather than this is not given. In between induced and naturally resistance, the tools are pretty much the same. The tools, whether this is drug transporter, affected stress transporter, or target overexpression, the end product, that it's resistant, is the same. This brings me just to one practical, then my time is over. This brings me just to one practical approach, that antifungal susceptibility testing is important. And if you go only for molecular tests for ACEs, you need to be aware that you need to test the whole combination, because the reason for resistance is multiple. And if it's for the echinocandins, you can focus on the FTS genes. So with this, I would like to conclude. The resistance is given here, is spreading now, depends within the clinical setting, the type of fungal diseases, the class of antifungal agents, and also to treatment duration. Thank you very much.
Thank you so much. Thank you so much, Connie, for this wonderful presentation. And you know, towards the end, also mentioning, of course, the emergence of Candida parapsilosis resistance, azole resistance, which is really striking, as you mentioned, because it's not driven by azole use. And many of these resistant isolates, because of the survival benefit, can affect patients that have never seen an azole, actually. I mean, we all see azole in the food we eat, but at least not have been treated with an azole. So I think that's really something we have to keep an eye out.
That's it. I think it's important.
So we have, of course, a number of questions, and none of them is easy to answer, because we heard from you that, you know, it's not the same. It's not the same in terms of resistance, how resistance emerges. It's not the same between the drugs, and it's also not the same between the species that we are seeing. But generally, overview, maybe summarizing what's most important. What is most important measure to counteract the emergence of MDR? Speaking over all the different species and resistance.
I think most important to treat the target, to get a name to the target, because it's a huge difference targeting Clobreda versus parapsilosis versus Aspergillus. So all the people should try to come to a good diagnosis. Next is, please avoid sub-inhibitoric concentration. Let's come on and don't use fluconazole with 100 milligram per kilogram. Wow, forget it, because you give the fungus what exactly he is wanting. Sub-inhibitory concentration. Hit hard and early probably is here, which is valid also for the bacteria. And a third, which is also important for me, there might be patients doing well, let's say suffering from Candida parapsilosis and an echinocandin. Go back and look to the patients. I think the clinical situation has more priority than the lab. The thing I would like to stress out, that if you go then for resistance testing, and the MIC is a little bit higher, but the patient is doing well, please move on with whatever the patient is doing well. Because the resistance testing or the breakpoints, they are very close nowadays. So it's not that tricky. So for me, it's always first in vivo, second in vitro. That's it.
Very quick question. I mean, there's a number of questions coming in, obviously. Are you aware of any differences in terms of systemic versus topical treatment of triggering resistance development? Is there any data?
There are older data coming from the HIV population, that it seems the usage of fluconazole triggers more resistance in superficial infections rather than in systemic infection. But whether this is really valid today, I don't know.
Perfect. And maybe another quick question, because there's so many extremely interesting questions which we need to
probably I can't give the answer, because but, you know, it's just by accident. It's
So one more, is there are there certain Candida species that are more prone to build biofilm formations?
Yeah, that's a very interesting question, to be honest, really very, very of interest. There is Candida albicans producing these biofilms, but there is also Candida parapsilosis producing these biofilms. And my understanding is that the biofilm from albicans seems to be much stronger in comparison to parapsilosis. So my understanding is that it depends from strain to strain, and not also from strain to strain, but also from nutrition. So which glucose, which I don't know, appetizers has the fungus to produce the biofilms?
Can I just quickly follow up a question here, Connie?
Yeah.
When you want to treat a Candida biofilm, and you have basically all gases available because they're all susceptible, is there any favorite class of antifungals you would go for to treat a Candida biofilm?
No. To be honest, I am not experienced with this kind of question from my own experience. I just can say that from the literature, it is thought that the echinocandins are better than the acels. This is what we know from the literature, but my personal, if it's a cassator, take it out, if it's possible. Yeah. Of course, there are clinical situations where you can't take it out, then you have to deal, but
yeah, I totally agree. If we see a biofilm in the clinical routine, we infectious disease doctor likes to get the material out, no matter where it is, basically. If it's possible, we try to get it out. Yeah.
Otherwise, you have a permanent source.
That's true.
Spreading the fungus into the blood.
Thank you so much, Connie. So I think there's a number of still very interesting questions. I will kind of like go in and try to answer.
I will check. Maybe.
And if you can check, but in the interest of time and to not have Dennis wait too long, I will hand over now to Juergen to introduce Dennis and the clinical talk.
Yeah, thank you, Martin. It's my pleasure to actually come to the last talk today, which is held by Dr. Neofytos from Switzerland. He's working at the Division of Infectious Diseases at the University Hospital of Geneva. And Dr. Neofytos has extensively published on infections in transplant recipients, solid organ transplants, as well as hematopoietic stem cell transplant recipients. And he will give us an overview on Candidemia, Candidiasis, and deep-seated Candida infections after surgery, which is always interesting to see because there's always like lots of things to think of, like source control, etc. So Dennis, please go ahead and give us a talk. Thank you.
Thanks, Juergen. And thank you for inviting me to participate in this wonderful webinar. It's a hard task to follow such interesting presentations that have already been presented, but I'll do my best. And in the interest of time, I'll move on. Here's a slide with my disclosures. And this is a very simplistic way of summarizing what I'm going to talk today in the next 30 minutes or so. So we'll briefly touch on the epidemiology presentation, mainly on diagnosis, and less so on the treatment of Candidemia and invasive Candidiasis, and we'll end with some future perspectives. So I think it's already been illustrated in the course of this webinar that Candidemia has been and still remains a major problem in clinical practice. And I think that despite and regardless whether we deal with resistant or not organisms, we have all encountered in our practice an increased frequency of Candidemia. And in fact, literature suggests that the Candidemia incidence has increased by almost 50% in the last decade, with an incidence between 3 and 16 episodes per 1,000 admissions. And if we look at Candidemia in different series, we can appreciate that it represents perhaps the 4th most common cause of bloodstream infections, depending, of course, on patient population. But what is more important, and this is a very old slide coming from an old study, but it also illustrates the important shift in the Candidemia species, witnessing even in the early 90s a shift from the albicans to non-albicans Candida species, which has been very well described in multiple different patient populations. And on this slide on the left side, we see data from the Path Alliance group in the US and Canada, summarizing data from transplant recipients showing that non-albicans Candida species in patients after a transplantation with Candidemia outnumbered Candida albicans. And the same was very well illustrated by Mike Fowler's study in general population, showing that Candida albicans has become the second most common identified species after all other Candida species together, which was not the case before. But the distribution of Candida species in patients with Candidemia varies based on the patient populations. And I think Connie has already alluded to that. And what I would like to point to your attention for today's discussion is that when we look at surgical patients, we see that Candida albicans remains the most commonly identified species, but we also have patients with Candida parapsilosis, Candida glabrata, and also some patients with Candida tropicalis and Candida krusei. Of course, in today's world, someone always needs to mention Candida auris, which in certain surgical patients and ICUs can be a problem, not a significant problem in Switzerland for the time being. We've only had one case in our institution, but definitely on the rise. And when we think of Candidemia and invasive candidiasis, of course, the risk factors are very well described in multiple different publications. And where does Candida come from? It comes from the skin, and therefore presence of central lines is a significant risk factor for Candidemia, but it also comes from the gut. And that's why patients who had abdominal surgery, gastrointestinal tract perforations and leaks remain at a significantly higher risk for an invasive Candida infection as compared to other medical patients, for instance. In addition, administration of broad-spectrum antibiotics, TPN, and the acute renal failure requiring hemodialysis, all suggestive of critically ill patients, have been identified as significant risk factors. And that is then not a surprise that the major patient populations affected by those infections, in addition to hematology patients, are patients who received a solid organ transplantation. And for the purposes of this presentation, when I refer to SOT recipients, I mainly refer to liver transplant recipients who represent a particular category of organ transplant recipients, but also patients in the ICU and surgical patients, particularly after abdominal surgery. And when Candidiasis presents in those patients, it can present in 3 different types. And this may be a very simplistic slide, but at the same time, it's a very telling slide, because when we think of Candida infections, invasive Candida infections, we mainly think of Candidemia. But Candidemia may be diagnosed or present without a deep-seated Candida infections, but also with a deep-seated Candida infections. And there are also deep-seated Candida infections that may not present with Candidemia, and those present the major diagnostic conundrum, if you will, in clinical practice. And those are the patients that we do not want to miss. And in the next couple of slides, I will try to touch on all those 3 different entities. And in the end, we'll spend more time discussing deep-seated candidiasis without Candidemia. But before doing so, it's worth reviewing briefly what do we define as an invasive candidiasis. And I think that we all agree with the definition of Candidemia being proven Candida infections based on the presence of Candida species in the blood culture. But when Candidemia does not exist and we look for an invasive candidiasis and a deep-seated Candida infection, then we look for histopathologic evidence of Candida species presence in a biopsy from a normally sterile site. That means that for all other cases where Candida species are identified in a normally sterile site, we are faced with a diagnosis of probable infection. Although in the official MSG EORTC guidelines published in 2019, The probable infection included host clinical and microbiological criteria as for probable aspergillosis, but for the host criteria, ICU patients or patients with abdominal surgery were not included. Therefore, if we have the presence of Candida in a deep tissue, in an abdominal tissue or abdominal a sample in a patient with a clinical signs of invasive candidiasis, by formal guidelines and formal definitions, we may not even be able to assign this patient with a diagnosis of probable infection. And this is not trivial, because as you can appreciate on this slide, efforts to define candidiasis in ICU patients have, for the time being, not been very successful for many reasons, particularly because of the variability of those patients and the difficulty of definitively defining candidiasis in the setting. So if we look at what we know is a proven infection of candidemia, candidemia may present with and without a deep-seated infection. Presentation is pretty much similar in both settings, with a febrile syndrome, sometimes sepsis. But there is some variations when we look at those two different entities and in terms of different patient populations. So if we have a patient with hematologic malignancy and neutropenia who develops candidemia, we may also encounter a diffuse rash or diffuse reticulonodular lung lesions, which are attributed to hematogenous dissemination of the organism in the skin or in the lungs. And we would also need to rule out endophthalmitis by doing a dilated eye exam within the first 7 to 10 days of candidemia diagnosis. In terms of deep-seated infections, if we think of a hematology patient, those patients are more likely to develop what we call as hepatosplenic candidiasis. And hepatosplenic candidiasis is a completely different clinical entity. It may and may not present with candidemia. And the reason that it may not present with candidemia is because the pathophysiology is the invasion of liver and spleen based on the portal circulation and not through a hematogenous regular spread. And therefore, those two organs are predominantly affected, and sometimes we may also see candidemia associated with it. We usually see this infection presenting with persistent fever in the setting of neutropenia resolution. But for today's presentation, and if we want to focus mainly on patients with abdominal surgery and patients in the ICU, deep-seated candidiasis predominantly present either with peritonitis or with the presence of an abdominal abscess with or without candidemia. And if we focus on those patients with candidemia, we have to mention that this diagnosis, as anticipated, is predominantly made with blood cultures. And the sensitivity of blood cultures historically has been considered to be in the range of 50%. And this is based on data coming from the 80s and 90s with autopsy studies, comparing autopsy findings with concomitantly with blood culture positivity. But we know that since then we've made some progress, and we think that the sensitivity of blood cultures in patients with candidiasis may be in the range of 70 to 85%. Lo and behold, we don't necessarily have a gold standard to accurately assess the performance of blood cultures. And we also know that blood culture sensitivity depends on the inoculum of organisms, but we also know that it depends on the presence of transient, intermittent, or high-grade candidemia. So in patients with deep-seated infections, as for instance, patients with abdominal infections, we may not always detect the organism in the blood because the candidemia may be either low level or intermittent, and therefore blood cultures may miss the organism. We might have made some more progress using fungal blood cultures, and fungal media have perhaps increased our ability to detect Candida species in blood cultures, mainly by enriching the agar with sucrose to enhance fungal recovery, and also by suppressing bacterial growth with the administration of antibiotics. And perhaps fungal blood cultures have been associated with higher sensitivity in detecting Candida glabrata, but not so much more in non-Candida glabrata Candida species. Lo and behold, today in most hospitals we use Malditoff, and matrix-assisted laser desorption has been associated with perhaps higher rates of Candida detection, which also gives us the opportunity to perhaps detect and identify the Candida species much faster than previously, and therefore within hours of blood culture growth, we may be able to also have the name of an organism, which is quite significant in clinical practice, particularly when we think of the different susceptibilities of variable Candida species. However, nevertheless, if we only use blood cultures, we may still miss a significant number of invasive Candidiasis cases. What is that number? We don't know. We hypothesize that it may be somewhere between 25 and 50% of cases, as it was illustrated by this very interesting editorial by Neil Clancy and Hong Nguyen. But who are those patients who present deep-seated infections without Candidemia? And as I've already alluded to, there may be patients in the surgical ICU after abdominal surgery or liver transplant recipients with intra-abdominal infections that do not necessarily give high-grade Candidemia, and therefore our ability to detect by blood cultures may be further hindered. Their presentation is not significantly different from what someone would expect. Those patients still present with fever, sometimes a fever of unknown origin. We do detect abdominal collections and risk factor associated with the detection of the diagnosis of a deep-seated invasive Candidiasis are listed here, and they're, I guess, for this audience, not a significant surprise. And most of these data are in agreement with what has been reported by the EUCandic project led by Matteo Bossetti. And as we can appreciate on this figure on the right side, the incidence of Candidemia in high-risk ICU patients can be up to 5 or 6 episodes per 1,000 ICU admissions. And when we look at the incidence of intra-abdominal Candidiasis without Candidemia, the incidence may be lower, but it's still quite significant, and we don't want to miss those patients. And why do we not need to miss those patients? Is because the associated mortality in patients with invasive Candidiasis is quite high. And if we look at data from different studies, and I've only listed 2 here, the ICU and the AMARCAND-2 studies, mortality can be as high as 40 to 70% in patients with Candidemia, and as high as 25% in patients with intra-abdominal Candidiasis. Another reason that we may not want to miss those patients is antibiotic and antifungal stewardship. And as you can see on this slide, the AMARCAND-2 study very nicely illustrated this with a study of more than 800 patients in France that that were studied. And what this study showed was that only 13% of patients received early and appropriate treatment for invasive Candidiasis, and 1/3 of patients had their treatment started not in time. But what was even more striking was that more than half of the patients treated in this study did not really need to be treated. And not only did they not need to be treated, but the treatment was maintained for more than 10 days in most cases. Therefore, the importance to accurately diagnose invasive Candidiasis, particularly in patients without Candidemia, is to, one, optimize clinical outcomes by giving treatment to those patients that need it, but at the same time, to not give treatment in patients that do not need it, so that we can avoid adverse events that are associated with the administration of antifungal agents, to decrease selection pressure, but also to decrease hospital costs that are quite significant. And how can we do that? We can use non-traditional microbiological means to make the diagnosis. And the T2 magnetic resonance or T2 test has been introduced in clinical practice quite a while ago, and it seems to be quite a helpful tool. I have to admit and I have to confess that it's not a test we use in our institution, and I don't have personal experience with it, but it's a powerful tool to diagnose patients with Candidemia with a sensitivity and specificity higher of 99 and 91% respectively when compared with blood cultures in patients with Candidemia. Its benefit is that it can give us an answer very fast. Within 5 hours, we may have a diagnosis. However, it has some hurdles, and those are that, first and foremost, it only detects 5 Candida species that are listed here, and it does not differentiate between Candida albicans and Candida tropicalis, and between Candida glabrata and Candida krusei. What's more important for the purposes of this talk is that there's limited data on test performance in patients with intra-abdominal candidiasis with a sensitivity reported as low as 30%. And in addition, as I already mentioned, its access is quite limited, as most centers do not provide the option to perform T2 MRI testing for Candidemia. However, two tests that have perhaps been more widely used are the beta-D-glucan and molecular testing. The beta-D-glucan test is a test that has been widely used, I think, until in today's world, and we have obtained quite an experience, both in the microbiological lab also, as well as in the clinical practice. It has a sensitivity somewhere between 75 and 85%, depending on many different factors that we're going to mention, and a specificity of 80%. Its sensitivity varies based on many different reasons. One, it may depend on the patient population. It was initially studied and validated in hematology patients with neutropenia, where the sensitivity was quite high. However, its performance may vary based on the variable cutoffs used and introduced in clinical practice, based on the number of positive tests required. Some guidelines require 2 consecutive positive tests to define positivity, based on the time and frequency of testing, but also based on availability. Perhaps not all tertiary care centers have beta-D-glucan testing offered to their clinicians. And of course, by its lack of specificity, as we appreciate that beta-D-glucan is part of almost all fungi, and almost all fungi, perhaps except for Mucorales and Cryptococcus, would give a positive beta-D-glucan. Therefore, a positivity does not always mean an invasive candidiasis. False positive results can also occur, and this is quite pertinent, particularly in ICU patients who may be on hemodialysis or who may receive albumin or IVIG, as all those have been associated with false positive beta-D-glucan results. Perhaps less commonly used is PCR testing in the blood, despite the fact that its sensitivity and specificity are quite high. The problems here are the lack of availability, but also the lack of standardized PCR methods across different institutions. And I also think that the uptake in clinical practice there is quite limited, as our experience, at least in clinical practice, remains quite limited. However, those 2 tests represent perhaps the future in terms of defining and identifying patients with invasive candidiasis. And this was first illustrated and demonstrated by the Pittsburgh group. And Neil Clancy and Hoenigl put a very beautifully run study together back in the late 2000s, where they prospectively enrolled patients with Candidemia or deep-seated candidiasis at their institution over the period of 3 years. They were able to identify 55 patients with invasive candidiasis, 17 of whom had Candidemia only, 33 deep-seated candidiasis, and 5 had both. And they compared those patients with 73 controls, and they tried those controls to be not simple controls, but also patients that were either colonized by Candida or had a new causal infection with Candida infection in an effort to further strengthen their clinical observations. And what we see on this table, which may be a bit crowded and a bit complicated, but I will try to guide you through this, is that when we look at PCR or beta-glucan for all patients with invasive candidiasis, only those patients with Candidemia, deep-seated candidiasis, or intra-abdominal candidiasis, we see that the performance of PCR was quite high, particularly in patients with deep-seated candidiasis and intra-abdominal candidiasis, with 89 and 80% sensitivity. That was significantly better than the performance of beta-glucan with p-values of 0.004 and less than 0.001 in intra-abdominal candidiasis. But when they looked at all cases of invasive candidiasis together, they also observed the same results, that PCR performs better than beta-glucan, and that was quite significant, whereas in patients with Candidemia, there was really no significant difference. What was more important that this study showed was that in the 24 patients with deep-seated candidiasis that had blood cultures performed at the same time, PCR and beta-glucan performed significantly better than blood cultures, which were positive only in 17% of cases versus 88 and 62% for PCR and beta-glucan respectively. And perhaps an even more important observation was that the sensitivity of combining blood cultures with PCR or blood cultures with beta-glucan was also quite improved, with 98% sensitivity when someone combined blood cultures with PCR, and almost 80% sensitivity when combining blood cultures and beta-glucan respectively. So this study really opened up the venue to further investigate this field, because we were faced with results that showed that if we don't use PCR or beta-glucan, we may indeed miss quite a number of cases. And similar findings were reported by the Funginus group, which is the fungal infection network of Switzerland, in a study published almost 10 years ago. And in this study that was performed in 2 main hospitals in Switzerland, in Lausanne and in Basel, 437 consecutive adult patients in the ICU were screened to identify 89 patients with significant risk for intra-abdominal candidiasis. And those were patients who either had abdominal surgery with recurrent, with many recurrences, or patients with acute pancreatitis. Even in this very high-risk group, only 1/3 of those patients were diagnosed with intra-abdominal candidiasis. And from those patients that were 29 in absolute number, only 2 had a positive blood culture. And that was quite striking, because more than 80% of patients with intra-abdominal candidiasis would have been missed had it not been for a beta-glucan, which demonstrated a sensitivity and specificity of 65 and 78% respectively. And in fact, the authors showed that if we use the beta-glucan, we would make the diagnosis of intra-abdominal candidiasis earlier by 5 days. And we all know the importance of treatment initiation as early as possible to optimize clinical outcomes in patients with candidiasis. And if we look at those two figures from the same study, I think those two figures are quite telling, particularly here on the left, we see that patients who were not colonized had very low beta-glucan levels, whereas patients who were diagnosed with intra-abdominal candidiasis had quite high levels of beta-glucan, and patients that were colonized were somewhere in between. So with this in mind, many groups have tried to see if and how we can use beta-glucan to guide antifungal therapy in the ICU setting. And I'm starting with a multi-center randomized controlled clinical trial that was performed in 18 ICUs, the so-called Candidemia clinical trial, in which beta-glucan was used to initiate antifungal therapy in patients at high risk. So what these investigators did was to take all patients at high risk in 18 ICUs and to randomize them in 2 different groups. The control group, which would be patients who would get antifungal therapy if their blood cultures or if their abdominal collection cultures would become positive, and the beta-glucan group, in which antifungal therapy would be started if beta-glucan became positive. The primary endpoint of this study was mortality at 1 month post ICU, post treatment, post ICU admission. And what we can see is that only 14% of patients were diagnosed with invasive candidiasis. And in the beta-glucan group, almost half of the patients received treatment, whereas in the control group, only 6% were treated. Someone would think, okay, perhaps we gave treatment in more patients, and perhaps we were able to optimize clinical outcome and save some of those patients that would normally not be treated. But mortality, which was the primary endpoint, was absolutely the same in both groups. And as you can see on this Kaplan-Meier survival curve, there was really no difference between the 2 groups. And in predefined subgroup analysis, the outcomes were absolutely the same. So the conclusion of this study was that serum beta-glucan guided antifungal treatment in high-risk ICU patients did not really improve 20-day mortality. And I think this was not a surprise if we think of the statistical power to detect a difference, particularly when we think of the prevalence of candidiasis in the ICU, which is perhaps in the range of 5 and 10%. And if with that prevalence, even with a sensitivity of 85% of beta-glucan, the positive predictive value of the beta-glucan would be below 15%. Therefore, those results were not necessarily a surprise. However, if we take a 5% prevalence and in a high-risk population such as in the ICU, we know that the negative predictive value of the beta-glucan is quite high, in the range of 90%, 95%. And this was taken into consideration in the design of this Italian study that enrolled prospectively patients in a single center ICU. And the goal was to randomize patients again into groups. One would be the beta-glucan group, in which patients would have a beta-glucan measurements on admission and every 2 to 3 days until day 14, and the control group. The intervention would be that in the beta-glucan group, antifungal, if there was a suspicion for invasive candidiasis, antifungals would be started, but if beta-glucan was negative, then antifungal empirical therapy would be discontinued. In contrast, in the control group, antifungal therapy would be continued for 2 weeks. The primary endpoint was not mortality, it was antifungal treatment duration. And lo and behold, the duration of treatment was significantly lower in the beta-glucan group compared to the control group. Interestingly, but not surprisingly, there were no differences in terms of invasive candidiasis rates, mechanical ventilation, ICU stay, or ICU mortality. And this is also shown in the major two figures of this study, showing here on the upper side the significant drop in antifungal therapy in the beta-glucan group as compared to the control group, and the absolutely similar survival rate in both groups. Pretty much the same results were observed in the STAF study performed in France this time. And the design was not that different, prospectively randomized, controlled, single-center, unblinded ICU study. In addition to beta-glucan, mannan and anti-mannan serum assays were also performed on days 0 and 4. And once again, we had the beta-glucan and the control groups. And in the beta-glucan group, antifungal therapy would be stopped if biomarkers were negative. The primary endpoint was similar to the Italian study, early within the first week antifungal treatment discontinuation. And again, in the beta-glucan group, treatment was discontinued in more than 50% of the patients, while treatment was discontinued earlier only in 2% in the control group. Similarly, antifungal treatment duration was significantly longer in the control group. And again, no differences in invasive candidiasis, mechanical ventilation, ICU stay, and mortality were observed. This study is followed by a follow-up study, which is ongoing and enrolling patients in Lille, and we're all eagerly waiting for the results of this follow-up study to draw more definitive conclusions. I will not spend much time because of the interest of time on the treatment of invasive candidiasis, but I will refer all to the IDSA guidelines, which I think is the standard of care in most centers. But I think we have all appreciated from the previous talks that anakinocandin seems to be the appropriate initial therapy for the treatment of candidemia and invasive candidiasis, and if possible to de-escalate to fluconazole, considering the Candida species and the antibiograms obtained, that is also recommended. In those guidelines, fluconazole seems to be the preferred agent for the treatment of Candida parapsilosis infections, but I would urge all to remember Connie's comment of the spread of fluconazole-resistant Candida parapsilosis in today's world. Central lines, particularly in surgical ICU patients, should be removed. We should not forget to perform a dilated eye exam to rule out endophthalmitis, because that would have significant implications in terms of duration of treatment. I don't recommend doing a dilated eye exam in the very early diagnosis of candidemia because we may miss it. It usually takes some days for those lesions to develop, so I usually recommend doing it in 5-7 days after the diagnosis. Treatment duration is between 14 and 28 days, depending on the presence or not of endophthalmitis or other secondary sequelae, starting to count from the first negative blood cultures. Now, it should be mentioned that there are special considerations for different patients. So, for instance, in liver transplant recipients, we tend to avoid azoles because of their potential hepatotoxicity, and we favor the use of echinocandins. The same for patients who have been on prior fluconazole prophylaxis. And we should also not forget the different penetrations in different tissues between fluconazole, other azoles, and echinocandins. So to conclude and to summarize what I tried to convey to you in the last 20-30 minutes or so, is that the diagnosis of invasive candidiasis remains challenging even in 2022, particularly when we think of deep-seated intra-abdominal candidiasis, for which, depending on blood cultures, is probably an outdated approach, and for which we do need better diagnostic assets. including a beta-glucan and molecular diagnostics. We shouldn't forget the potential limitations of both those tests and the fact that those tests, without using them in conjunction with the patient that we have in front of our eyes, and also in conjunction with our local hospital epidemiology, may not always be of help. I think that future clinical trials are important so that we can better understand and define deep-seated invasive candidiasis, but also the appropriate use of fungal biomarkers, predominantly beta-glucan, in terms of empirical versus preemptive versus targeted therapy. And clinical expertise remains a key factor to successfully diagnose, request the appropriate diagnostic test, and perform therapeutic procedures, including administering the right antifungal therapy for optimal clinical outcomes. So with this, I will end, and I will let Martin continue.
Oh, unmuted. Thank you so much, Dennis, for very important and big Swiss contribution to our joint hosted webinar. Thank you so much for a wonderful talk. I do have a few questions, and I will rush a bit over in the interest of time. And one maybe that's interesting is what is the clinical impact, in your opinion, on the limited differentiation between strains with the T2MR assay? I mean, I understand you don't have it here, but you can imagine basically if you had it, what would be the clinical impact for you?
Yeah, I think that I think that it depends on which patient population we're talking about. If we mainly focus on the ICU surgical patients, I think that the data there are not that great, meaning that the sensitivity is somewhere between 30 and 50%. So for this specific patient population, I think that it could not necessarily be a significant asset. However, in the hematology patient, where we do need to have diagnosis the earliest possible so that we can initiate the appropriate therapy, I think there would make a significant difference based on the fast turnaround time that we can get the diagnosis within.
I mean, one issue may be in the presence of emerging species, of course, that this is not easily adapted to detect some of these emerging species, right? Like Candida auris or something. So there may be caused some delay. I mean, you probably still need culture. You can't rely alone on T2MR. Yeah.
No, and that's the main reason our laboratory has not really embraced this test. And I have to say that with most colleagues that I have talked to, I haven't heard not even one single colleague that use it. I don't know if, Connie, you're using it at your hospital or not.
Even Juergen, my co-chair, basically has some experience, because I think we had it for a while. I mean, maybe not this current type, but Juergen, what is your experience? You had it for a while and evaluated the test, right, in Graz, before coming to you, Connie. Sorry.
Yeah, that's true. We had it for study purposes, I think, for a year or something like this. What we observed is we had some kind of technical issues, so a lot of invalid results, which is not so good if a single test is like 150 euros or something like this. And actually, we missed a few blood culture proven Candidemia cases with actually species that were per se included in the T2 panel. So we were not completely convinced. Maybe it's some kind of like an evolving process for this whole T2 thing, and we were kind of early, so we had it like 3 years ago or something like this. So maybe that improved. But we had this issue with invalid results and few, but we did see cases that were negative for T2 positive in the blood culture. Yeah, Connie, maybe Connie, your thoughts.
Connie, what is your opinion? Do you have some personal experience?
Yes, we have, but no more to add.
Okay.
Several invalid, and for me, finally, strange results.
Okay.
So actually, to use it for me, or let's say just to use it, it's too expensive. Because it costs, I don't know, 500 euro a sample. And this is also important having in the background.
Yeah.
Thanks so much, Connie. So I feel a lot of agreement yet that, this is, of course, an exciting technology, but maybe for many centers not yet ready for prime time for different reasons. Yeah, thanks.
I think so. Okay, I think we're a little bit behind the time, Martin. So maybe you want to jump over to the closing points?
Yes, let me share my screen. First of all, I definitely want to thank all the presenters today. Juergen, and I also want to thank you, Juergen, as co-chair for guiding together with me through the very interesting discussions. I think this was a wonderful webinar to conclude our 2022 webinar series. I want to thank again, basically, of course, the organizers, the ECMM, together with Healthbook, and also Gilead Sciences, and some other sponsors. And it's also my pleasure, because this is the last webinar of 2022, to wish you all already nice holidays, beautiful Christmas, and a Happy New Year. Thank you so much, everyone, and have a wonderful rest of the evening or day, wherever you are in the world. Thank you.
Thank you, Martin.